I've been really passionate about advocating for ADCs in the first line for metastatic TNBC for a while now, and the primary reason is not the de novo metastatics, but it's the relapse setting. Because for years now in the United States, the KEYNOTE 522 trial has been the standard of care, and you're getting, carboplatin, paclitaxel, pembrolizumab, adriamycin, and cyclophosphamide, 5 drugs in that setting, and then yet we still have some of these patients that relapse early. I mean, that's very common in metastatic TNBC. If they're going to relapse, usually it's within even the first 2 years. Um, but they represent a more resistant patient population that they've already been treated with 5 drugs. And so the idea of treating them with something that they just received, it doesn't make a lot of treatment sense to me as far as mechanism of action and resistance. And so, as well as CNS disease, because that is a huge issue in metastatic triple negative breast cancer. We know that these patients, if they live long enough, often get, brain metastasis or leptomeningeal disease. So brain penetration is also something that I think is extremely important. So, certainly for these relapsed or patients, I think treating them with a different mechanism of action, these topoisomerase 1 inhibitor ADCs, makes a lot of sense. As far as the de novo metastatic patient population, these updated trials that we're going to discuss did include those patients as well. And, I think putting your best foot forward and, strongest medication here, if we are truly losing 50% of the patient population by the second line, makes sense.
Yeah, I think, dividing up and understanding that better is a big goal for the future. But, I think in this setting, we don't understand sequencing well. But if a patient has, really resistant triple negative breast cancer, or, most patients have visceral disease with triple negative disease, you know, putting your best foot forward seems like the best approach. And for me also, controlling the disease for as long as possible in that first line setting means you're treating patients in the best shape. Their bone marrows are better, they tolerate treatment better, they have less of the end organ effects of treatment, and they're just less beat up by treatment overall. So I do think that that will make a difference.